Welcome back, ladies and gentlemen. I hope you had a nice first part of the day. We're really sorry. As you may have seen, we experienced a few technical issues, and we are trying to solve this as soon as possible. So we hope everything will be as it's best this afternoon. Now let's move to the second plenary of the day, which topic is the following: health orientation of healthcare services by management systems. How model and standards of good practices. For this plenary, we will have 3 keynote speakers as well as 2 co-chairs. We will have Marianne Aucher here with us, as well as Heli Hatunen. Sorry for the pronunciation, not sure about that. Ladies and gentlemen, I wish you a constructive and enriching session.
Dear participants, thank you to be here with us for this second plenary session. I'm really happy to have you on board today. This afternoon, I have the great pleasure to co-chair this session with Heli. Heli, might you introduce yourself to our participants, please?
Hello everyone, and good afternoon also. And my name is Heli Hatunen, and I'm a vice chair of the International HPH Network, and I also work as a ministerial advisor in the Ministry of Social Affairs and Health in Finland. So it's my pleasure to chair this plenary session today.
Thank you so much, Heli, for your introduction. I can also introduce myself. So I'm Marianne Aucher. I'm from the RESPAD. The RESPAD is the local host of today's conference, of this year HPH Conference. I'm also a resources and development manager in this French association. And I'm very happy to be here with you to talk about the nice subject of health orientation of healthcare services by management systems, how models and standards of good practices. This morning, you had a first plenary session talking about what is health orientation of health services through management systems and why governance models should be health-oriented and should balance health outcomes, ethical and economic aspects. This afternoon, in this second plenary session, we will focus on how to implement those strategies through management systems, and we will see several standards and models of good practice. To do so, we will have the great pleasure to have with us 3 keynotes.
Yes, I hope my mic is open. Yes, and policy research in University of Exeter. And then we have, may I say, a little bit more practical viewpoint of the topic for the topic by hearing the model of good practice from France. I think it's very presentation is given by Frederic BATTEUX, who is Director of Strategy and Transformation Department, Publique-Hôpitaux in Paris. And finally, we will have a kind of different kind of perspective, also very interesting presentation, HPH Standards and e-learning, which is very important in the area of the health promotion. And presentation is given by Oliver Krohn, who is CEO of the International HPH Secretariat, vice chair of the board at Optimedis in Germany. So we are going to have a very interesting plenary session, and I really ask you all participants to time at the end of each presentation to have a discussion, and I think that the most important thing to have these kind of conferences is to have time also to discuss and share our ideas and comments together. So I give the floor Professor Jose Valderas. Please, floor is yours.
Thank you very much for your very kind introduction. I hope you're all hearing me well. We have a very brief time for introducing some issues related to value-based healthcare, the promises and realities, and I've tried to summarize what may be perhaps the most interesting aspects of the current status of the art, of the knowledge on value-based healthcare, current initiatives, and a proposal for a research agenda. Not included here is that I'm actually a GP, a practicing GP, so I'm not just preaching from the ivory tower of academia, but also with day-to-day clinical practice. So the next slide. Okay, so because we have this little time, perhaps let's try to capture everything in one single slide, and then we'll see what else we can talk about. So we need to some very fundamental guiding principles for improving healthcare performance. And whereas in the previous decades, the emphasis has been mostly to reward performance based on adherence to best evidence with a focus on care processes. Now there is an emerging recognition that there needs to be a focus on the outcomes that are achieved. And this is in a nutshell what we are talking about when we're talking about value-based healthcare. So what are the outcomes, not what the system does in order to achieve the hypothetical or the desired outcomes. And within this framework, there's a particular role for outcomes that matter most to patients. This would be particularly patient-reported outcomes, but also there's a place for patient-reported experiences of care, which is the perceptions of individuals of how care is delivered to them, including how they are engaged in it. And crucially, I hope I will be able to argue that value-based healthcare can be instrumental in reorienting healthcare for meeting the needs of people who suffer from multiple health conditions, multimorbidity. So, what are we talking about when we're talking about value-based healthcare? Well, basically, it's about the guiding principle that we were after is value, and it's the ratio of what are the outcomes that are achieved based on the resources that are put into the system to achieve those outcomes. And value-based healthcare is healthcare that maximizes this ratio. Some proponents want to add experience of care to outcomes, which to some degree is related to the process of care, but as appraised by the ultimate recipient. And so there's, whereas canonically, typically, we would be talking about outcomes in relation to resources, I wouldn't necessarily say that we need to leave experience out of the equation. What this quotient brings together is basically in a almost in a single equation that Berwick's triple aim of improving health outcomes, experience of care, while reducing costs. And you have to the right-hand side of your slide some of these measurements that are being typically used for measure these different concepts. What are outcomes? Well, outcomes, you can use the traditional 5Ds approach: death, disease, disability, discomfort, dissatisfaction, which are shorthand for perhaps more nuanced list of relevant constructs. But if you check this list, what you will see is that many of the things that we include as outcomes are ideally or best elicited as coming directly from the patient, from how severe a disease is to what is the function that an individual can or cannot perform, what's the level of symptoms, or what are higher level constructs such as general health perceptions or health-related quality of life. So this I would hope, very clearly places patient-reported outcomes in a very critical place in relation to what health systems aim to achieve. If we're thinking in terms of patient-reported outcomes measures, so this is again a canonical definition by the Food and Drug Administration, any health measurement of a patient health status that comes directly from a patient. And to those of you who may have been less exposed to them, so basically you have a stimulus, a question, a set of items, you have a response scale, and you have some system for combining the response scales into scoring. What do they measure? They measure symptoms, they measure function, they measure health, general health perceptions, they measure health-related quality of life. Some of the reasons why you will be hearing about patient-reported outcomes is that some conceptual problems in teasing out these different constructs triggered the FDA to focus in, okay, what's these measurements? I mean, what was the source of these measurements? The patient themselves. And shifting the focus from what was being measured to the source. This is an attempt of combining both the international classification from functioning by the WHO, in particular its conceptual model, with the Wilson and Cleary model of patient-reported outcomes, which is very well known in the literature, basically highlighting that, yeah, it's true that we may be using different terminology, but the general concepts of symptoms, of function, and of higher constructs like health-related quality of life are always there in one way or the other. Does it make sense to use patient-reported outcomes in clinical practice? So we are now in the third iteration of putting together the evidence for distilling an answer to this question. And it was submitted, I think it must be published literally today, the results of this Cochrane review. So I'll be disseminating via Twitter as soon as I get the confirmation. What we studied is whether, what was the randomized control trial evidence of what is the impact of providing patients and clinicians with information on patient-reported outcome measures, and what is the impact in particular along this cascade of effects, whether it improved patient communication, rates of diagnosis and notations, whether it made any difference in terms of the treatment, the disease control that was eventually achieved, the different domains of functioning, physical, mental, social, and eventually whether there was any difference in quality of life. And so this slide is only to tell you that although we reviewed 115 randomized controlled clinical trials, only a handful were available for any given outcome. So for instance, we can see is in terms of communication, we found three reasonably strong randomized controlled trials that we were able to combine and that demonstrated a positive impact, feeding back information on prompts to clinicians and patients results in improved communication. And we explored the whole cascade of effects to confirm, for instance, as well, that there was a very small yet significant effect on improving the quality of life of those patients. You have here a summary of the results. And what we can see is a leaking pipeline. Or perhaps more familiar to a health services researcher, the closer you are to the intervention, the bigger the effect. So when we're talking about feeding back information on prompts to clinicians and patients, that stimulates communication between the two main actors, and the acts of diagnosis, less so treatment and disease control, but higher order constructs are also, you can see impact on some of them, but not in all of them. In the few minutes available, I would like to raise your attention, to bring your attention to main international initiatives that are of interest in value-based healthcare, which focuses heavily on the evaluation of outcomes for improving the whole process of care, and which heavily relies on patient-reported outcomes. HPH has triggered a movement which had previously not seldom been seen in relation to the interest in health outcomes, in patient-reported outcomes. So far, they've created a large number of core outcome sets, which basically clearly and neatly define what variables, what outcomes need to be considered for all patients with a given condition along the whole pathway of care. It can be surgery, or it can be primary care, or it can be even self-management. But these are the whole set of outcomes that should be considered for each patient with this condition. HPH, for instance, has now recently released a whole outcome set for overall adult health, in which they aim to capture, and I've been very grateful to be able to chair, we've been able to capture overall health for the perspective of an individual adult. The main benefit is that it brings together the different set of outcomes that you have seen in previous in a previous slide. And as you can see here, all the information is patient reported in the form of prompts. PROM is Global 10, the WHO Wellbeing Index 5, and also another WHO functioning instrument. Another initiative I wanted to raise your attention to bring your attention, is PARIS. The PARIS Initiative, whereby the Organization for the Economic Cooperation and Development, the OECD, which brings together the most developed countries in the world and an increasingly larger number of countries too. And the OECD has a well-established measures of system performance, and with PARIS, which is framed, perhaps you may be familiar with PISA for education. So PARIS aims to do the same for health system performance from as patient reported. And the idea is to develop these indicators using patient-reported information. That would be indicators of experience and outcomes of care. And a consortium has been commissioned by OECD to develop these indicators. And what I'm sharing here is the provisional, it's the current framework. They may include some minor tweaks, but not too many in the foreseeable future. And again, you say as patient-reported outcomes, symptoms, functioning, self-reported health, and health-related quality of life. One thing that value-based healthcare can really be a disruptor in is in relation to tailoring care for people with multiple conditions. So if we consider that disease models have along the history of medicine and health systems inform models of care, we can start with one disease model of the infectious disease, typically one condition, one agent, one treatment, which lend itself to the disease-specific, disease specialist approach, a sequential model of diagnosis, treatment, and follow-up, if needed. When with the epidemiological transition, the emergence of chronic diseases, it was recognized that, okay, we're still talking about one condition, but we recognize there are multiple agents and multiple treatments. So we're no longer thinking in terms of just a disease specialist, but rather a multidisciplinary team in a cycle model of diagnosis, treatment, and monitoring. Cycle, probably more like a spiral. And what multimorbidity does is add a completely new layer in which we recognize that it's not just one condition, it's multiple of them. It's not true that patients come up with neatly defined problems which are based on a single condition. So we're no longer talking about a multidisciplinary team, but rather multidisciplinary teams. And the model is not no longer a cycle, but rather a system model with identification of trade-offs, of goals, which are the outcomes that we've been talking about in value-based healthcare, and networks. And what is recognizable is an increasing whole patient focus in this transition from the infectious disease model to the chronic disease model to the multimorbidity model. what do we still need in terms for value-based healthcare to be fully implementable and to work at its best? We need the identification of process for identifying values and preferences. We have an idea of how to do it, but the evidence is perhaps not there yet. We need to develop the systems for collecting the data. In particular, preference-based computerized adaptive testing is looking particularly promising. We need to know what information to feedback to patients, clinicians, managers, and policymakers, which may not necessarily be the same. And the current model is to provide the same type of information, perhaps overall scores for patients at different levels of aggregation to the different actors. Maybe that's not the right approach. Maybe we need something more sophisticated for each of the recipients. Also, what is the role of outcomes-based evaluation in the financing of healthcare? Because professionals will probably have some resistance to have their salaries tied up to outcomes which are very removed from everyday experience of care. Plenty of things that we need to know about implementation. And then the evaluation of in terms of impact of the triple aim itself. I mean, this is the promise of value-based healthcare, but does it really? I mean, does it really deliver? We obviously recognize the elements in the equations. Doesn't really mean that it does work. We all hope it does, and there is emerging evidence that it does. For instance, based on the Cochrane review that will be published. But we need to accumulate more evidence. This is the summary of what was being said. I'm aware I'm a couple of minutes above my allocated time, so I'll just leave it there, and I will be very happy to answer any questions.
Very nice presentation, Professor Valderas. I think it was very interesting and also
Thank
very
you,
useful.
Mr. Valderas. This was very, very interesting presentation.
Thank you.
Yes, I was just saying that it was very interesting and I think very useful to have both the definitions of quite theoretical concepts and then the applications on more concrete fields. So I think that's very interesting to have those both point of views. I was wondering about some participants' questions. If you have some questions, you might just ask in the dedicated space on the platform. I think that we don't have any question right now, but I have some for you, if I may ask. The first one was about the main role of patients. To what extent do you think they should be involved in such a health promotion strategy in hospitals?
I think that patients are the main providers of care over 99% of the time, in the sense that they provide care to themselves. They follow the indications as provided by health professionals at home in their everyday life. So it's any model that does not acknowledge their absolutely central role, even as in terms of ensuring that care is delivered as even within a very paternalistic model of care, it will be in the end up to them to decide how to implement it, how much to adhere to it, how to follow it, or rather seek alternative approaches. So I think they're absolutely central. It does not mean that they necessarily have all the relevant information always at hand or experience for making their decisions in isolation. So this recognition needs to go hand in hand with supporting them in making sense of the information provided and supporting them in making the right decisions. So those both things, I think, go hand in hand and will be critical to any model that deserves the name patient-centered.
Okay, thank you for this answer. And I think it's important to remember that patients are both the target of health promotion actions, but also the actors, yes. And we have now a question from one of our participants about the barriers to overcome in implementing PROMs. Do you have some answers to these questions?
So one of the main barriers, there are main barriers which are technical, so implementation of systems that are well aligned with everyday practice. So very much like people want to know what's the glycosylated hemoglobin of their patients without having to go out of the way of getting the information. So you need patient-reported outcome systems which elicit information in the same way. That also applies to the interpretation of those scores. So it cannot be left to the clinician to dig somewhere else to make sense of what this 75 out of 100 means. So the availability of the information needs to be contextualized with the right information. I think plenty of support. The information does not necessarily is somewhat new in the system, depending on the specialties, and there is some minor resistance from clinicians in terms of measures based on patient reports that perhaps consider to be less useful than other more technologically oriented measurements. And I must say that to them that there is strong evidence that they are as good as technology developed measurements for predicting, for prognosis, for further use of health services, for even mortality. So these are by no means something that would be nice to have. They are actually very useful and actionable information.
Thank you so much, Professor, for your intervention and the answers to the questions. And I think we can just go on with Oliver Grohn's presentation about the new HPH standards. Thank you, Oliver.
Thank you very much for the opportunity to speak today. Can you hear me well?
Yes, perfect.
Perfect, thanks. So I think I would try to link a couple of the things we've heard earlier and address the question how we can translate cutting edge of research, as we've heard from Professor VALDERAS, and the practical example of a hospital into a tool that can facilitate the implementation of health promotion in a wider set of organizations. I'm just, yes, here we go. Thank you. So before I go on the standards that I will explain in greater detail, I want to say a few words about the network and the strategy, because not everyone might be aware about the current state of that. So first, as many of you know, the HPH network has been around for many years, so over 30 years. We currently have about 600 members all over the globe, organized in 20 different networks and representing 33 countries at present. There might be 2 more countries joining very soon. We are in good discussions with a number of members to join. And the network structure has changed or is changing. Traditionally, this has been a network of hospitals, but increasingly we are incorporating other health services along the continuum of care, which is a very important development. And I'm speaking on behalf of the Secretariat, which is based in Hamburg in Germany. Professor VALDERAS already addressed some of the issues in moving from a health system or health services that focus on disease or a set of disease or multiple disease to health services that focus on patients' needs, comorbidities. And we have had an intense process in the last year to update our strategy and values to reflect those developments. And as a vision of the network, we have now stated that our aim is to orient governance models, structures and processes and cultures, optimizing health gain of populations and support sustainable societies. So we have really a broad vision that goes much beyond individual health or risk factors. We also have a set of values and principles which are very well aligned with a development towards a health system focusing on health gain rather on disease. The new definition that was developed last year really stresses that health promotion goes beyond the individual professional and the evidence that we have amassed over the last 10 years on consultations, on modification of risk factors, on patient education, and rather focusing more on the responsibility of the organization to embrace a set of principles and evidence in their decision making. So we're focusing a lot on the governance models now. We also put more emphasis now on the topic of health gain. And I will come back to the issue of how we are going to measure that and the support to sustainable societies. The work we have conducted on the 2020 standards, and which I had the honor to chair last year, builds on a set of standards that was developed during my time with the World Health Organization almost 15 years ago. And that was a first intent to develop a tool that translates all the evidence and guidance for hospitals into a language that many managers and professionals understand, namely the language of standards, standards for care, standards for conduct, standards for organizations. And this tool has been very successful. It has been translated into many different languages. And over the years, various working groups in the network have started to develop tools and standards for specific target groups, such as the elderly or children, or on topics that are very relevant in the context of the network, such as health literacy. And building on the work of Dr. Eugenio Cerenza some years ago, who set out to propose a set of umbrella standards, we then worked with a working group and the task forces to unite the different standards, reflect on current evidence, and prepare a new tool, which are the new 2020 HPH standards. In order to do that, we convened an expert panel. We had a two-stage Delphi panel to set the scope of the standards, to define our conceptual framework, but also to elicit key topics for standards. And that was a process that was very intense, took a year of time, had 7 different phases from the expert panel discussion and the working group discussions. And as a result of that, we have now a new set of standards developed together with our partners in the different HPH networks. The standards are online. You can find them online. They've been published there, and there are 5 standards with overall roughly or nearly 100 different elements. And these standards address organizational commitment for HPH, access, people-centered care, creating a healthy workplace, and promoting health in the wider society. And it has been the intent and the challenge to reflect in these standards all those elements which are part of the HPH principles, but also reflecting on newest evidence that are linked to certain standards, and to reduce the complexity of some of the research. You could see that earlier on some of the research on prompts in a Cochrane review. These are very comprehensive documents, and some of these evidence needed to be translated into clearly understandable action-oriented statements, which reflect this evidence, but also reflect a broader development in the health sector. I'm going to highlight some new developments or some new topics of these standards in a moment. So as a first standard, which is on demonstrating organizational commitment for health promotion, for health promoting hospitals, we have put a lot of attention now on embedding of structures to support health promotion through leadership and policy. This is particularly relevant because as I mentioned earlier, in the last 10 years, we had put a lot of attention on health promotion in the professional patient interaction, which is, of course, a very relevant topic and which is meant to stay and critical to implementing health promotion. But we had the last years less attention to the role of management and governance structures. So we have now embedded structures, or we have embedded standards that clearly reflect the organizational responsibility, and particularly also pointing to leaders' responsibility to support the implementation of all those goals, principles, and tools that help to optimize health gain. We also put a lot of attention on the monitoring bit, monitoring, implementation, and evaluation, so that we can support organizations to measure the extent to which they're actually able to implement the standards, but more importantly, improve the health gain for patient, staff, and population, and demonstrate their impact in this field. The second standard is named ensuring access to the service, and this goes far beyond the physical access. The physical access, of course, is part of the standard, but is actually also included in many national legislations about healthcare services. So we have added to this access component the less tangible factors, such as how to navigate a system. That's often a challenge. Certainly when I have to visit a hospital, I often get lost. So there must be something about navigation that is inherently complex in hospitals, but can be made easier if attention is put on this issue. But also access in terms of the health literacy environment. We might access a organization physically, but we might get lost because the language or the signage is not in line with what we expect or what we are able to comprehend. And that is particularly important for patients or family members who, in a situation of stress or experience ill health, have to navigate complex organization and find themselves confronted with language and signage that doesn't help them orient easier. But access also includes further issues such as the social, cultural acceptability and the awareness and respect for needs and preferences within the community. The third standard really embraces a lot of the research on PROMs and PREMs and patient-centered care and patient involvement. And this has become a very dense standard in the sense that it has many components, many items to be assessed, many of which build on the research on improving patient-centered healthcare. We have also included standards to address specifically the role of shared decision-making and decision tools that should be used in that context, and also the fundamental topic of patient empowerment, fundamental because it's one of the key pillars of health promotion. And here we draw heavily on latest evidence on self-management interventions and supporting behavioral change. And we've included that because we believe it is very important that such patient empowerment actions, which are often delegated to the primary care, are actually initiated in the hospital setting, but also are planned more coherently between the primary and secondary care interface, so that when a patient is discharged from the hospital, he or she is actually well prepared to take an active role in the management of his or her condition. And I think Professor VALDERAS just said, patients are the main provider of care in 90% of the time. So once we discharge them from the hospital, we really need to make sure they know what are the next steps, the symptoms, how to take the medication, how to navigate the subsequent care process. The fourth standards addresses particularly the staff and the working condition in the hospital. We did have such a standard already in the previous standard set that we developed 15 years ago, but we've much expanded that. we have focused on the one hand much stronger on the role of the organization to ensure that the working conditions are appropriate in terms of addressing and being aware of staff health needs, involving staff, and offering health promotion activities and resources. And here we added a fundamental issue as well from the health promotion perspective, where the old standards focused a lot on the individual staff members. We have now focused much more on the settings approach and on the factors to create a work environment that supports health and healthy behavior. And that includes even issues linked to procurement of food and planetary health diets and all the other very relevant topics that we've heard in some of the parallel sessions earlier today. The last standard addresses promoting health in the wider society. And this is, on the one hand, linking the hospital or health services to other organizations that are working in the healthcare field. There might also be organizations that work at the community level, which are more working in the social health domain. But a lot of health issues are linked to social issues. So these linkages are very important. We've also incorporated the work of our task force on the environment and have included standards that address the environmental effects of hospitals and health services. And you know that from the Lancet Commission report, healthcare contributes 5 to 10% of CO2 equivalent emissions. And therefore, it's very important that healthcare services embrace this role and find ways to reduce their CO2 equivalent impact in order to address the climate crisis. These standards released earlier this year, or yeah, actually it was earlier this year, even though they're called 2020, have all been translated in 4 languages, and various translations are in process. So we're very glad to see that and to provide also the information on those standards on our website. I just want to share a few more ideas or notes on the current work that we've been doing. In the last half year, we have developed measurable elements. These are the items that can be observed in a healthcare organization and that allows the assessment of compliance or adherence or progress with a standard. So here, to understand the hierarchy, we have a standard statement with an objective. We have dimensions of that standard, which here, for example, the leadership. And then under the leadership are actually the specific standard statements. And together with our partners and networks, we have now developed measurable elements that can be assessed or observed in the organizations. We are also developing resources, tools, and evidence that help organizations improve on those standards. One thing is measurement, but the other thing is improvement. And we are developing an online platform that collects all this information and tools to support our members in improving the implementation of these standards and improving the impact. How can these measurable elements and standards be used? There are different purposes, some linked to internal quality improvement and self-assessment, others linked to external assessment. The main goal is really that we want to facilitate member organizations to assess how they're doing and to find ways to improve. So that is the self-assessment bit. But we're also aware that some organizations have been successful in actually incorporating some of these standards into regional or national standard sets and working with accreditation agencies, particularly, for example, in the context of Catalonia, but also in Taiwan, where our partners have been working with the authorities to integrate some of the standards. So the standards can be used for various ends, but the key goal for which we have developed them from the Secretariat is really to help the learning process. This just to illustrate the different steps that we followed to develop those measurable elements. It has been a lot of work. with a lot of feedback and good comments from our experts and from our networks. And we are pleased to say that we're just finalizing this tool and we'll be able to present it to our General Assembly next month. And based on that, we can then develop our online platform and facilitate members and help members improve on those standards. So that was it from my side. These are the contact details. Please reach out if you've got any questions, and I'm looking forward to the discussion. Thank you.
Thank you so much, Oliver, for this presentation, for the clear details on the 5 new HPH standards. I know from reliable sources that this document is already very useful for some structures in France, so I think it's the same also worldwide. We don't have any questions from our participants right now. Heli, do you have some elements? Okay, so
yes,
I think
I hope you can hear me better now. So
Heli, we can't hear you.
but I think do we have any different organizations? Because I think okay.
Yeah, I'm so sorry, Heli, but we can't hear you properly. We just have some words. I'm very, very sorry about this. In the meantime, I just received a question for you, Oliver. The question is the following. In your opinion, who is the healthcare system is best suited to assess how well a healthcare organization fulfills the standards? So who is the best, maybe the best person, the best, yes, the best services?
If I understand the question correctly, it's about asking who would in the healthcare system would be best suited to assess.
Yes, absolutely.
Oh, well, okay.
Yeah.
Well, as I said, I believe these standards are most useful and constructive if they are embraced by an organization's leadership with the intention to use them as a yardstick, as a measurement basis, as baseline assessment on how well the organization is doing in relation to the health promotion standards. It is then the responsibility of all the departments and professionals to contribute to that, but it must be the leadership of the organization, because a lot of these standards have responsibilities that go across individual departments or across individual specialties. So while this in the past has often been the basis to start a HPH member hospital, and also a lot of the research and project developed on that basis, I believe, and that has been also the topic for this conference, that we need to get the senior management much more involved in implementing these standards. I also emphasize that while the standards could be used by other organizations, such as accreditation organizations or perhaps other organizations in the healthcare system, to conduct external assessment. External assessment may not include the same incentives for individuals and organizations to engage in this process. External assessment might lead to a stronger focus on reaching a certain minimum requirement, or in the extreme a tick box exercise, whereas internal assessment or self-assessment is probably more driven by the intent of learning, with the risk that the learning is biased or limited by those actually driving the process. So in answer there, I think risks and potentials to conduct both self-assessment and accreditation. If it's used for external assessment, it needs to be clearly designed to provide the right incentives. And if it's used for self-assessment, it clearly needs to be supported by management and senior leadership in order to unfold the best possible impact.
Thank you so much for your answer. And I think you're right, we're reaching the point of the conference, which is to remember the importance of governance and of management systems in implementing health promotion strategies, because they have, yes, an essential role in those actions. I have a last question for you, which is about the tracking progress process you talked about. Will there be like a score to evaluate an improvement in the applications of standards? How will it work?
Okay, so next month at the General Assembly, we'll present the tool, and there will be 3 different outputs. First, we'll produce a document in PDF format, and for each of the measurable elements, there will be a 10-point scale where you can rate your process. I could expand on why it's a 10-point scale, but basically we wanted something a bit more granular than we had in the past, where we only had 3 categories, to actually measure progress and be more sensitive to changes. So that tool will be presented. Secondly, we are developing a spreadsheet, which is currently being designed, so that hospitals can use the spreadsheet to actually collect information and produce scores and reports on the different standards and their performance. And again, with the aim to be sensitive to measurement and improvement. And the third output will be this online tool that I alluded to, that is still being developed, and that will focus less on the scoring and more on identifying any kind of resources that might help a manager, professional, or group of people to actually implement and improve those standards, because in some cases you might need to look for additional evidence or literature, and we are compiling this at the moment and make it available to our members.
Thank you very much, Oliver. It was quite clear, and I think that some structures will be very happy to have this tool to evaluate their progress in the strategy. I also think that we're quite running out of time and that the session will end quite soon. If one of you have just one word maybe to conclude on this session, I will be happy to hear. Okay, so I think everyone agreed on the fact that health promotion is targeting both healthcare practitioners and patients, that patients and all the stakeholders should be involved. And now we have some tools and some ideas on how to implement the strategy, some dedicated actions on various topics. I think that could help some of us in our structures. Thank you, dear speakers, for your very nice presentations. Thank you also to participants for their questions. I think this plenary session was really complementary to the first one this morning, and that it will be very useful. After this presentation, who was very relevant to the topic of the importance of governance and management systems, please do not leave the session, because we will meet again in a few seconds for the closing session. Once again, thank you to all of you. Dear participants, hello again for those who were with us just before during the second plenary session. We're now meeting again for the closing words. For these closing words, I will have the pleasure to talk with both Bodzena and Ilaria. They will have few words for you, and first I would like to have also some words after the plenary session of this conference. First, I would like to say how delighted we were to have been with you during this session, during this day of conference. It was very enriching, very constructive to have you and to have all the speakers and participants. I really hope that the topics answered your question, that the formats, even if we encountered some troubles, were very useful for all of you, and that you will be able to implement some tools that you learned about. We heard plenty of ideas, of tools, practices that were mentioned to achieve this mission of health-oriented healthcare management systems, and hopefully all of your questions were answered. As I mentioned before, we were facing some severe failure which which didn't allow us to broadcast all the contents of the parallel session we would have loved to. But don't worry, we will fix the issue and we will record all the parallel sessions in order to make them available for all of you as soon as possible. So you will have an access to all of those parallel sessions and content. After those apologies, I would like also to have some thanks word for all of our partners. First, I would like to thank the HPH board members, Bodzena is here, but also Margareta before, for having trusted us and supporting us in the development and organization of this conference. It was a really good opportunity for the RESPAD, for the French network to be emphasized, to be highlighted, and for our members also to have this visibility. Also, we are very happy to be part of this global action on a worldwide topic. A huge thank you also to the Secretariat team, because they were always daily very helpful, very supportive, and a huge thank you for all you did and all we learned with you. It has always been a great pleasure to work with this team. Thank you also for our partners, for supporting the project, for being involved in the scientific committee, whose role was huge, and for your kind communication on the events. Finally, thank you to all of those who worked on the event, who made this day possible. And of course, thank you to each of you behind your screen for being here, for asking questions, for the exchanges that we saw during the day. Developing health promotion worldwide is very important for us since a long time, and it's very great to be part of it like this. We also hope that despite the current health crisis, you enjoyed the contents and you enjoyed this conference with this virtual format. And before Bodzena and Ilaria's last words, I just want to remind you that you will have a dedicated access, unlimited, to all contents during 15 days, both parallel sessions, the plenary you saw during the day, and the exhibition room for posters. Maybe, Bodzena, you want to have some word for our participants after this very enriching day.
Yes, thank you very much. I would pass some closing remarks. I see that this conference has provided an excellent analysis of the topical themes of health promotion. Healthcare alone cannot promote the health of the population, but it plays an important role in this task. And health promotion should be part of the strategic management of healthcare organizations, everyday practice, as well as the assessment of the activities. We should use the assessment tools that were presented by Oliver for evaluation of our activities. The participants discussed an important topic on how can health promotion optimize health gain and create more sustainable and equitable health system. The COVID crisis has affected us all, as I said at the beginning of our conference, and changed our everyday lives in many ways. It has also shown that those in a vulnerable position suffer the most from the crisis. And again, the crisis made visible how important health is, how important a sustainable and equitable health system are to keep resilience of societies. Again, it is important that healthy living habits are very substantial for the health of the society. And we now know how and why we should educate people. The world around is constantly changing. Again, VUCA world that I mentioned. And our activities have to be in line with this changing world. Health promotion requires continuous renewal. Health promotion has to address today's challenges. It has to change, and our activities should be agile. The reform requires research information, scientifically proven information, And so we can use this in the development of the best practices. The HPH network provides an excellent forum for this work, and the network should be used to share new ideas and good practices, as our conferences are the best and ideal place to exchange this best practices. I would like warmly thank all of you, ladies and gentlemen, for your active participation. I want to thank all the presenters for interesting presentation. I enjoyed it really very much. In particular, I would like to thank the French HPH Network, RESPAT, for organizing this conference with help of our Austrian friends from conference secretariat. And I saw how much work it needs to prepare such a conference, especially that this conference is the first in our history that is virtual. So congratulations. I want to thank Scientific Committee again for preparing the content of this conference, and thank you all for contributing to this interesting day. Thank you very much for your attention, and I thought I would say something about, and I have a kind of surprise for you. But as you see about the next conference, but as you see on the screen, there won't be too much surprise anymore. I would like to pass the floor to Ilaria to tell us about the next conference that will take place in 2022. Thank you very much again.
Thank you, Bozena. As next year conference, we chose Riva del Garda in Italy. Our topic for the conference is mainly dedicated to the pandemic, to the lessons learned from science and society. And I think it could be a good occasion to compare our views, practices, and to make a reflection upon what happened in these years. The proposed date is in October of next year, and we are trying to do it in presence. So this is our challenge for the next conference. I would like to, okay. Your host for next year is the Healthcare Trust of the Autonomous Province of Trento. Perhaps not many of you know our region. We are an autonomous province in northern Italy, very close to Riva del Garda, and we have a unique healthcare trust for all the territorial level that promotes and protects the health of citizens, both individually and collectively. This is our mission, and we are we could say very new to this, because before 1995, we were 11 local health units, and we turned into one only recently, we could say. But we managed to keep together our activity through 7 hospitals, 4 health districts, and 3 structural departments. So we are huge, but very determined, to contribute to the health promotion cause, as Paris did this year. For the budget, we are still discussing. Perhaps you have seen this presentation also at the last GA. The budget has to be discussed, but we are trying to keep it very low in order to switch also to a virtual kind of conference, because with COVID, you never know what happens. So basically, we are trying to contain the costs, also to contain the fees, and to have this possibility to switch from an in-presence to a virtual conference if the situation gets worse. Hopefully it doesn't. And we are trying to manage all the venue and the conference features that you already know, that you've seen the past years. And on the fees, we are trying to, as I said before, keep the estimate low, but we are starting from the World Bank criteria and gradually lower the rates if we have many participants. So it wouldn't be bad if if we could have also a provisional participants list at the beginning of next year, could give us a first idea on how many people would be interested in participating in presence in Riva del Garda. This is it. Was very quick, so you are very welcome to Riva del Garda. We are waiting for you finally, face to face. I would like to thank you all for the attention and for this year conference. Really, there were technical problems, but it was a great challenge and really, really important conference. So thank you.
Thank you, Bodzena. Thank you, Ilaria, for your kind words and encouraging words also. We faced several issues, but I think that the conference was great, as you said. Before letting the floor, I will just have a few words to introduce you to Marco, who you met already, for the end of the program of the day, because the day is not yet over.
Yeah, it's not over yet, and we still have many good things to come, as you might know. We still have 2 slots with a few different parallel sessions, so we cross fingers for everything to work properly. Remember, as Marion said, we have a replay, so everything that you haven't been able to assist, we will do our best to put you on replay for posters, for parallel sessions and the plenaries. You have 15 days to watch all that in replay. As far as I'm concerned, it has been a pleasure to be your host today, and hopefully I'll see you, Ilaria, ci vediamo l'anno prossimo in Italia forse, fammi sapere. Thank you very much all, and congratulations for this event. Still a few things to come this afternoon. Have a nice day.